Okay. Hello, good evening, everyone. Welcome you all for this live webinar, Oncology Cancer Treatment Updates 2023. With the immense pleasure, I would like to invite Program Director, Sir Dr. Sunil Kumar Gupta, sir. Sir is Director and HOD Department of Hemato Medical Oncology, Bone Marrow Transplant, Venkateshwar Hospital, New Delhi. Welcome you, sir. Over to you, sir, for further proceedings. Hello, Sunil, sir.
Yes, very good evening, dear friends. At the outset, really thank the sponsor of this scientific program who has given me this opportunity to interact with you people. Today, we have an oncology cancer treatment update and December 2023. This means we are running the last month of this year, and next year we will again discuss new things regarding the cancer treatment. Today, we have an update on lung cancer, and we have a galaxy of consultant here. We have a 3 speaker followed by a panel discussion by me. But before that, I would like to discuss few things regarding this scientific program. We are discussing about the recent development in lung cancer treatment in this scientific program. This is a scientific feast. We will also discuss about the magnitude of this disease globally as well as in India. We will discuss the role of biomarker in the lung cancer treatment, past and current status of these markers, what is the implementation of these markers in clinical practice as a targeted therapy. We will also discuss about the guidelines and journey of next generation sequencing, followed by overview of lung cancer, Globocon 2023 data. We will also discuss about the recent changes in the TNM classification of lung cancer, clinical evaluation and staging workup of lung cancer. We also discuss about the indications of mediastinoscopy despite of PET CT scan, landmark study, followed by decoding treatment option for EGFR mutation in lung cancer patient. My talk is basically, and my discussion is basically focused on adenocarcinoma, followed by a case-based discussion, panel discussion in managing early lung cancer, because there are so many things in early lung cancer. The adjuvant treatment, which drug, which chemotherapy, what are the clinical guidelines say, what is the real picture, and what are the trial says, we will discuss in the last. Once we will finish the specific 3 talk regarding the lung cancer, especially the adenocarcinoma. For the first deliberation, I would like to call Dr. Arpana Dhar. She is a director of hereditary and precision oncology and genetic counseling, Max Super Specialty Hospital, Delhi. And I would like to call Dr. Arpana Dhar for his talk. Her talk, sorry, please. Dr. Arpana Dhar, please.
Yeah, I'm here. Good evening, everybody.
Yes. Dr. Arpana Dhar.
Give me 1 second. Can you see my slides?
Yes.
All right, brilliant. Let's get started. So good evening, everybody. Thank you, organizers, for having me here today. So I've got quite the mammoth task. I'm going to walk you through essentially the molecular landscape of lung cancer. So without much further ado, let's get started. So what do we know about lung cancer? And, particularly our NSCLC cohort, we've learned that it's possibly one of the most molecularly diverse cancers. And just look at how we've evolved. We've gone from treating NSCLC as one large homogeneous group, and slowly we've moved on to categorizing it based on its histological subtypes. And from there, if you look at the adenocarcinoma subtype, which is the most common and is actually the most molecularly diverse. I also want to draw your attention over here to this, greater than 1 oncogenic driver mutation, which constitutes for around 3% of our cases. Do keep this in mind, because I'm going to revisit this just in a bit. So what does our landscape look like? So this is just a screenshot from NCCN guidelines, which recommends a minimum, and look at how we've changed, we've evolved, a minimum of EGFR, ALK, ROS1, BRAF, NTRK 1, 2, 3, MET exon 14, RET, PD-L1, you've even got KRAS 12C now. And Interestingly enough, it's not the adenocarcinoma only, it's even in the squamous cell where it's being recommended. And it's no more advanced. We're also doing NGS. We're at least doing molecular profiling even in the early stage because we know we have approvals for immunotherapy, and we do know that if there's an EGFR ALK or a ROS1 mutation, it can be contraindicated, which furthermore solidifies the fact that molecular profiling is becoming extremely important in our NSCLC cohort. So very quickly, let's just review what are the sample types for doing this molecular profiling. Tissue is the gold standard, no argument there. At diagnosis, you do a biopsy. At progression, you do a biopsy, preferably from the new metastatic site, and the samples get analyzed. But the ground reality is, while we'd like to, our blocks looking at least something like this, all too often tissue can be an issue. And to combat tissue being an issue, liquid biopsy is an excellent alternative. So you're essentially isolating the circulating tumor DNA, the ctDNA, not the CTC. ctDNA is the somatic DNA that is released from the cancer cell into the bloodstream. The ctDNA is isolated, and molecular profiling, like we do tumor profiling, is done. But some of the key concerns that we've always had around liquid biopsy is its concordance with tissue biopsy. In fact, we've had studies like SLIP, NILE, PEN2, and these studies have beautifully illustrated in lung cancer that liquid biopsy isn't inferior to tissue biopsy. And we've also got a couple of pros in doing liquid biopsy. For example, you can monitor, it's non-invasive, most importantly. So one, you can actually monitor response, you can detect resistance mutations, and you can tackle the issue of tumor heterogeneity. Now, in 2021, the IASCLC consensus statement, which was led by Dr. Christian Rolfo, we were reminded there are some key differences between tissue and liquid biopsy in lung cancer. While tissue biopsy, of course, we get a cancer diagnosis and pathology information and an assessment of markers like PD-L1 that is non-genomic. I know there are studies using CTC for detecting this, but that's a talk for some other day. So tissue biopsy essentially does take a very, very long time for the results to come, and it's also very challenging to repeat biopsies, and it's not always reflective of tumor heterogeneity. Now, liquid biopsy is found to be highly concordant, and it's fast, it's minimally invasive, and it's easy to repeat, and perhaps better to capture tumor heterogeneity. Although, unfortunately, while all of us cannot, send our patient sample to gold standards like Guardant or Tempus or Foundation Medicine, tissue testing is, turning out to be a little bit more sensitive versus liquid biopsy. So if you don't find something on liquid, it is important to do a reflex tissue. So what's the ideal profiling strategy? Now, in continuation with IASCLC to 2021 consensus statement, it was observed that in treatment-naive patients, there were at least 3 approaches that were recommended for liquid biopsy. 1, a sequential approach. Your tissue failed, so you go ahead and you do a liquid biopsy. 2nd, and this is something I think a lot of us are tending to lean towards now in our clinic, a complementary approach, upfront tissue and liquid. And the 3rd one is plasma first approach. So it's clear that we aren't going to have sufficient tissue or surgery, biopsy, the tumor is inaccessible, so we do liquid up front. So while there are many technologies available to call out variants, NGS is my preferred platform of choice, and I think all are preferred platform of choice. So I'm not belittling the standard of care of platforms like RT-PCR, FISH, IHC, but I feel that with NGS, we do get the answer to the tumor biology in one shot versus standard of care platforms. In addition, NGS is proving to be cost-effective, improved turnaround time, tissue preservation. But for me, I think what really stands out is that 1, it has the potential to discover novel actionable targets. 2, you remember at the start I showed you that 3% of the pie chart. It can actually call out those multiple oncogenic mutations, and NGS does this all in one sitting. So what it's doing is it's helping guide and chart out a more personalized treatment for our patients. So here's data from my clinic where we've seen that approximately 40% of patients did have an actionable biomarker, and we tested over 600 patients. And if you see, what was important for me was these concomitant mutations. Now we know that in the when you have EGFR with a TP53, I think it's from the FLORA2 studies where we know that you actually can give a TKI with chemotherapy. It has a better, outcome for our patients. Or when there's that MET lurking behind, we do know MET is going to be resistant, so we can monitor it using liquid biopsy. And these were some key takeaways we saw from my data set, from my clinic. And I think this is essentially where we are. These are the actionable biomarkers, that are available with their associated therapies. We've got a couple of new additions. You've got your NTRAX, RET, MET exon 14, and your KRAS 12C. So we're just very quickly going to browse through them. So NTRK1, 2, 3 are fusions. So they're very rare. They constitute for around 0.3% of our NSCLC cases. These are agnostic markers. And, these waterfall plots for entrectinib and larotrectinib illustrate that majority solid tumors, lung cancer included, responded very well to these TKIs. So what are we looking for? So essentially the rearrangement of the NTRK gene coupled with a tyrosine kinase domain with a 5' fusion partner to generate a chimeric TRK protein ligand binding domain. That's a tongue twister. In simple language, it's a fusion. And common fusions that we do see, fusion partners that we see in lung are NTRK1 with TPM3, we get NTRK3 with ETV6 with EML4, to name a few. How do we test this? Now, in the flowchart of the testing method, this is what's recommended by ESMO. But in my very humble opinion, we know that NTRKs are translocation speed 1, 2, 3. So NTRK3 has a very low sensitivity on IHC, whereas NTRK1 actually has a low sensitivity and specificity to FISH. Thus, the preferred platform is NGS, and particularly RNA NGS, as it's a fusion. Fusion RNA NGS has a higher sensitivity and specificity, and this is why it's becoming the preferred platform. And multiple international journals and publications are echoing the same. Now we move on to RET mutations. RET is synonymous with papillary thyroid carcinoma. Interestingly, it constitutes for around 2% of our NSCLC cases. RET gene is essentially, what are we looking for? We're looking for a rearrangement that gives rise to chimeric cytosolic proteins which constitutively activates a RET kinase domain. Now, KIF5B is one of the most common fusion partners that we see in NSCLC cases. And the preferred platform, again, it is a fusion, so it is going to be RNA NGS. Your therapy options are selpercatinib from the Libretto 001 study, and you've got pralsetinib, the Blue 667, which we get from the Arrow study. MET exon 14 skipping. MET exon 14 skipping is essentially a mutation at the junction of exon 13 and exon 14. The product fusion of exon 13 and exon 15 is formed, and that's what you're testing for. Preferred platform, no-brainer. It's a fusion RNA NGS. Actually, as a note, when you get a negative report for lung cancer, go back and check the methodology or call your service provider. If they have done DNA-based NGS, especially for your fusions, not just for NTRK, RET, MET, but your ROS ones, your ALK. Anytime you're looking for a fusion, it has to be RNA. So if DNA is not done, I very strongly recommend, as a reflex, change your service provider if needed. Do an RNA NGS. There is a high possibility they could have missed out on a particular fusion. So what are my treatment options in MET exon 14? You've got crizotinib from the Profile 1001 studies. You've got matinib from the Geometry trials, and then you've got tepotinib from our Vision trials. Now we've got KRAS. Now, KRAS mutations, we know, are the most common mutations in NSCLC. They constitute for around 25 to 33% of these cases, especially in our in our smoking cohort. They're interestingly mutually exclusive with EGFR and ALK mutations. So these are essentially, and this is why this mutation is so complicated and it's not very straightforward, is that because KRAS, these are essentially GTP binding proteins that connect to the tyrosine kinase receptor. And what this RAS pathway, what it does is it sends signals to a number of other cellular pathways that are involved in cell proliferation and survival. That's why it's so difficult to actually treat these KRAS positive, KRAS mutant tumors. Now, from the KRAS subtype, the G12C is the most common. It constitutes for around 40% of our KRAS cases. It's It's indicative of poor prognosis versus a wild-type KRAS. And what's even more interesting in KRAS in these subgroups is the varying TMB rates. So G13, has a high TMB rate followed by G12C, and G12D has a propensity for having a lower TMB. Even the PDL1, the TPS scores, which are greater than 50%, G12C is around is at around 41%, and G12D is around 35%. Now, doing a standalone test, these are point mutations, no brainer. It is NGS. We know sotorasib from the AMG 510 trials is your treatment option. We also got agacetarib, I can't even pronounce it, but those are also another targeted therapy that is available. And then we've got our exon 20 insertions, and actually quite interesting, these insertions. They constitute for around 12% of our EGFRs, and we know they're very, very different biology altogether. The reason I've put this up is that they're different insertion. There are different partners at different codons, and all of them have a very different response to different treatment types. So it's not always amivantamab. In some cases, they're very sensitive to afatinib. In some cases, it's amivantamab. So when you see an exon 20 insertion, please reach out to your molecular geneticist and let them look at the codon and tell you what would be the most ideal targeted treatment. Now, this talk would be incomplete if I don't talk about immunotherapy. So we know from the Keynote 010, we know from Checkmate 017 OAK trials that have very clearly demonstrated the utility of PD-L1, thus making it a recommended biomarker upfront. 3 clones, DACO22C3, we've got the Ventana SP263, Ventana SP142. But chemo, we've got different immunotherapy options based on the different TPS cutoff scores. We see if a patient is a candidate. Please note, in the presence of one of these oncogenic driver mutations, it's contraindicated. So if you have an oncogenic driver like EGFR, ALK, etc., your immunotherapy is not going to work. So tread very carefully when you are doing a PD-L1. Do wait for that NGS report before you start treating with immunotherapy. Now, another very interesting biomarker is tumor mutation burden. It's a slightly controversial marker for immunotherapy, especially in the case of lung cancer. So the key theory is that every cancer has a mutation, and more the mutation, higher the neoantigen load, and possibly a better immune response. So in a lab, on a minimum of a 250 gene panel, you look at the number of genetic aberrations in the exonic region, and this kind of gives you an indirect idea, if the tumor that you're dealing with, if it has a high neoantigen load or a low neoantigen load. However, here's where I think that there's a slight issue with this particular theory. Not every mutation will actually cause the tumor to have a neoantigen, and they may have antigens, but it may not necessarily be recognized by, that neoantigen may not be really recognized by the immune system. Thus, the neoantigen may not really, kind of induce an immune response that we're looking for. And again, there are multiple studies that have, Dr. David Gandera's group has done a couple of studies. In one place, it is 20 mutations per megabase pair. In some, it's 10. So what really classifies as a high cutoff? And I think that it's what is the ideal score for lung cancer? Like in PD-L1, we have different cutoffs for different solid tumors. I think we need to figure this out as to at what score does, will the neoantigen load actually induce the right immune response. So I think most studies, it's still experimental. However, the contradiction to all of this is that in the Keynote 158 trials, the FDA has given a blanket approval. So when you've got your backup across the wall, don't have an option, you can use TMB as one of your IO markers. But if your patient can afford, please go for something like a foundation medicine, because foundation, I think, is the only one with some sort of robust data in validating the TMB. Worst case scenario, you do have the Oncomine 409 TMB panel. You can consider that, because obviously everybody cannot afford a foundation, but try and stick towards a foundation, especially with TMB. And I'm not a spokesperson for foundation or Roche, just an FYI. So we've got all these mutations, but what do we do? The bottom line is we've listened to all of this. What really happens in our clinics? So I'm just going to walk you through what we do in our cancer genetics clinic. So in a newly case scenario, we do NGS upfront, ideally from a 12 to 20 gene actionable gene panel. That's those very classical gene NGS that we do for the lung cancer panel, and we do a PD-L1 in cases where patients can afford. We try doing NGS, we try doing liquid and tissue upfront together. I think what's really worked is when you have a conversation with your patients and you counsel them about the importance of doing, tissue and liquid, or you tell them you're going to do tissue, but if it comes negative, we can opt for liquid, and you don't have to do an expensive Guardant or a Foundation or a Tempus. A lot of the domestic partners, I think, where it comes to lung, are doing a really, really good job. So at least upfront, try and do those 12, 20 actionable biomarkers. I think it's really, really important. Don't do that 5-gene one. You need to know about your TP53s. You need your METs. You need your BRAFs. They are indicative. Your PIK3CA, these are known resistance genes that are there that could possibly tomorrow contraindicate your osimertinib or and also do a 12 to 20 gene lung panel. That's what we usually do in our treatment naive, and obviously PD-L1. Now, if a patient presents to the clinic on progression on or recurrence, we do take a biopsy from the new metastatic site. If it's not possible, we do a liquid biopsy. Again, in this case, I think, we've learned, and I'll try and show you a couple of cases, that if not liquid, let's just do tissue. Let's just do them upfront simultaneously together. The gold standard we do know is the Foundation, Guardant, and Tempus. However, if that's not there, panels that are validated panels from Thermo Fisher and Illumina are known to being darn good. Now, at this junction over here, I would opt for bigger panels. Now, I would not be doing a 10, 20 gene panel. Now, I want to go to a bigger panel. I want to understand what's happening with the tumor. Why was there resistance? Is there any sort of other acquired mutation? Is it a KEAP1? Is there an STK11? So at this point is when I would try and go for a comprehensive genomic panel. Now, what is a CGP? A CGP is essentially an assay that gives you your MSI, your TMB, your PD-L1, and all your actionable biomarkers. And it's essentially a 150, 200 gene panel. That is your CGP, where you get an answer to treatment and your immunotherapy. So I would be doing this at this particular point. So just very quickly, let me just walk you through 2-3 cases and I'll wrap up my talk. So this was a 50-year-old female who presented to our clinic. It was NSCLC. This was actually during COVID. I still remember this case. And at this point, we just went ahead and did a very classical sequential EGFR by RT-PCR, ALK by FISH. We did IHC, came negative, Reflex was done FISH, ROS1 was by FISH, PTL, everything one was negative. In the minute of COVID, she obviously did not want to come in for any sort of testing, any sort of chemotherapy. So at this point, we sent her block for NGS. Luckily, we did have tissue and we found a BRAF V600E, no-brainer. She was started on a combination of Debra with trametinib, a BRAF and a MEK inhibitor. As we know, they're always given together. This is a case of a 79-year-old male. He was EGFR positive. He was started on afatinib. He progressed. We did a rebiopsy and we did an NGS, and interestingly enough, no mutation was detected. And he's 79. I mean, you really want to subject him to chemo at this point. So we said, all right, as a reflex, let's do a liquid biopsy. We sent it for a liquid biopsy and they found a MET exon 14 skipping mutation. Now, what was very interesting over here is the VAF is just 0.4%. So in liquid biopsies, in a good liquid biopsy, the depth of coverage has to be a minimum of 15,000x. When the depth of coverage is 15,000x, the higher the depth, the sensitivity of the test increases. So you can call out mutations as low as 0.01. If it's at 20,000, if it's at 20,000x, you can actually detect something as low as 0.01. Versus your tissue biopsies, which laboratories do it at 500x, 1000x, where detecting mutations as low, or variant allele frequency as low as 0.4% is very, very slim. And also that because this was such a small mutation, just 0.4%, it also addresses the fact of tumor heterogeneity. And that's why complementary testing, if tissue is negative, do liquid. Liquid is negative, try and do tissue if tissue is possible. And this, I think, is a brilliant example. And this patient was started on capmatinib. And my last case is of an 81-year-old female. NSCLC tumor was insufficient. So upfront, we have done plasma first approach for her. A ROS1 fusion was detected, starting on crizotinib. She progressed, refused to do a tissue rebiopsy tissue. So we continued doing a liquid biopsy. The ROS1 fusion was persistent, but she had acquired a ROS1 G2101A mutation. This is a known crizotinib-resistant mutation. So her treating physician puts her on lorlatinib. It was unfortunately short-lived. She progresses, and again, a liquid biopsy was repeated. Now, The ROS1 fusion was persistent. She lost the G2101A, but she gained a G2032R. In addition to this, well, if you see, if I go back, sorry, if you see, she's lost the KRAS 117 and now has a KRAS 12D, where we know binimetinib is a possible target. Now, this could be a potential CHIP mutation. So when you are doing liquid biopsies, you have to be very careful of a CHIP mutation. So while we know ctDNA is fast becoming an actionable resource, we have to be aware of that the sample that we get is not just of the tumor, but also of the tumor in the patient, with cancer. But we're also seeing variants that are arising from both of the tumor and from the aging white blood cells. So these, what we have, are identified as clonal hematopoiesis of indeterminate potential CHIP mutations. And obviously, no one wants to say the rather long-winded name. So we call them CHIP mutations. Now, these mutations are not uncommon, especially in patients with lung cancers and those who are older. And as we remember, this patient of ours was 81 years old and have a history of smoking. So common CHIP mutations we see are, especially in lung, are TP53, KRAS, and JAK2. So if you see a VAP less than 0.1%, I would recommend, it is a CHIP, go back, double check with the laboratory if you are targeting a potential CHIP mutation. And I think for me, this slide, just this pie chart just best summarizes my talk. Around 50% of our patients with advanced NSCLC have a driver mutation, and that's targetable with some sort of FDA-approved agent, or there is, something in clinical trials that we have over here in red. And yeah, on that note, thank you very much for your patient listening.
Thank you, Dr. Atmadhar, for such an excellent talk in this stipulated time. I would like to call for a second talk, overview of lung cancer, by Dr. Bharat Dua. Dr. Bharat Dua is a consultant medical radiation oncologist at Venkateshwar Cancer Hospital, New Delhi. Dr. Bharat Dua, please. Dr. Bharat.
Yeah, good evening, sir. Am I audible?
Oh, yes, yes.
Yes, I'll just share my screen here. Right. So is my screen visible to everyone?
Yes.
Yes, sir, it is visible, but you have to make it full screen, please, on slideshow
Right.
mode.
That first slide, Dr. Bharat, first slide.
Right. Just hang on a second.
Okay.
Yeah, just make it full slide.
Yes.
Is it all right now?
Yes, Dr. Bharat.
Right. Right. So let's start. So good evening, everyone. My name is Dr. Bharat. I'm a consultant in the Department of Radiation Oncology at Venkateshwar Hospital. I would like to thank the organizers and Dr. Sunil Kumar Gupta for allowing me to speak in front of you today in this conference. And the topic of my discussion is an overview of lung cancer management. And let us begin. So if we were to look at the burden of lung cancer in India, so this is the Globocan 2020 data.
Bharat, your slide is not moving.
All right, just a second.
Yes. Yes. And full screen.
Yeah, just a minute, sir. Is it moving now, sir?
Moving, but I need a full screen.
Sir, if you permit it, can I share your slide, please?
I've actually made some changes, so just hang on a second. Is it moving now, sir, and is it full screen?
Not a full screen. If not full screen, Bharat, you can start your talk. There is no problem. We can see.
Okay, just a minute, sir. There seems to be a problem here. Is it full screen now, sir?
No. Now we can see.
Is it all right now, sir?
No. Same.
Okay, I think I'm going to have to ask Arham to put on my presentation. There seems to be some problem. Arham, could you run the presentation, please?
Yes, sir. Yes, sir. Just do stop sharing, sir.
All right. Right. All right. So should I start, Aram?
Yes, sir. Please. You just have to say next. I will change the slide.
Right. We were reviewing the Globocan 2020 data regarding the burden of lung cancer in India. And if you look at all cases as a whole in all sexes, so lung cancer constitutes about 5% of all cases. And if you look at males specifically, then the number rises slightly to about 8%. And if you look at in terms of the incidence, prevalence, and mortality, lung cancer ranks at about the fourth in terms of all cancers in India. Next slide, please. Yes, this is a very important slide. So, optimal staging is necessary to decide the best treatment option in lung cancer, and for that matter, any cancer. Now, there have been some significant changes from the 7th to the 8th edition, and I'd like to highlight all of them one by one. They are not all encircled in the slide, but they're very important to know. Now, all the changes that were made in the staging were decided by the ISCLC group. They reviewed their prospective and retrospective database and took a cohort of about 95,000 lung cancer patients. Now, for the first thing that they realized was for every 1 centimeter increase in the size, there's a decrease in the survival. So what they did was, in terms of T1 cancers, they divided them into T1A, B, C instead of the historical T1A and B. From 1 centimeter to 1 to 2 to 2 to 3, there's a significant fall in survival. This was the first thing that they did, and this resulted in a subgrouping of the staging of 1A into 1A1, 1A2, 1A3. This is the first change that was made. The second change that was made was at the level of T2B and T3 and T4. So historically, T3 used to be more than 7 centimeters, but now T3 has become anything greater than 5 to 7 centimeters. This is because tumors larger than 7 centimeters were found to have a very poor prognosis, a prognosis almost similar to the T4 tumors. So they were grouped in T4 now, and T3 became more than 5 to 7 centimeters. Now, consequently, this stage grouping resulted in stage 3 being divided into A, B, C instead of the historical 3A and B. And another important change that was made was in the M staging. Now, historically, we used to stage lung cancer as M1A and B, depending on whether the metastases were extra or intrathoracic. Uh, Now, what they have done is they've divided M1A, B, C. The reason that they've done this is M1B is single extrathoracic, M1C is multiple extrathoracic, and there's a marked difference both in terms of the therapeutic options and the prognosis for M1Bs versus M1Cs. And other changes are there. They've given new morphological groupings. There is more elucidation on the data on how to classify tumors as second primaries versus intrapulmonary metastasis, and these are best reviewed if you go through the original document. Next slide, please. So coming to the staging algorithm, so we have various modalities to stage lung cancer. Some are invasive and some are non-invasive. So our non-invasive modalities include a CCT of the chest, a PET-CT, and an MRI of the brain. I'll briefly mention how they are used. So CCT and PET is done in most tumors and as part of the initial staging. And an MRI brain at present is recommended for stage 1B and above, radiological stage 1B and above. The slightly more invasive modalities that we had to stage, say a lung is a bronchoscopy, a EBUS, EVAS, and a mediastinoscopy. And we'll be discussing this in some detail regarding the invasive mediastinal staging. Next slide, please. Coming to the radiological aspect of it, so a PET CT adds a bit of information to the CCT. Now, while a CT done can tell you about malignant nodes on the basis of size, it has been found that even nodes larger than 10 mm can be negative for malignancies as many as 40 to 50% of the cases. So a CT scan alone, if you use it to stage, has a low sensitivity and specificity for about 50 and 80% respectively. And what a PET CT does is it pushes this up significantly to about 80 and 95%. Next slide, please. Yes, so this is a very important concept that we need to know in early lung cancer, occult N2. The concept is that some particular patients, despite being negative radiologically for mediastinal nodes, when they undergo surgery, are found to have pathologically node positive disease. Now, these patients do not benefit from surgery as much as patients who have pathologically node negative disease. So there was this approach to figure out which patients are likely to have occult mediastinal nodes that is radiologically negative but pathologically positive. Various studies were done from by the thoracic, both the American and the European thoracic group. And when these studies were collated, it was found that there are three particular risk factors that are particularly associated with occult N2. So one was central tumors. The second was a tumor size being more than 3 centimeters, even if it's peripheral, that is in the outer 1/3 of the lung, and a higher SUV on PET. Some say 4, some say 6. But again, these risk factors are associated with patients having pathologically node positive disease and radiologically node negative disease. And it is in these patients where we might consider invasive mediastinal staging. Next slide, please. Coming to mediastinal staging, if you look at all the guidelines, NCCN, ESMO, up to date, all of them recommend a less invasive approach upfront, followed by an invasive approach, depending on certain factors, which we'll just go through. Next slide, please. Yes, so the mediastinal staging, this is the ISLC nodal map, and the initial techniques that are recommended for a mediastinal staging are a EBUS and a EUS, which are relatively less invasive than a mediastinoscopy. So these 14 nodal stations that are mentioned over here are mentioned for a very important reason. 1 to 10 are nodes that can give a designation of N2 or N3, and 10 to 14 can give a designation of N1 only if ipsilateral. Now, if you have contralateral hilar interlobar nodes, then the designation goes up to N3. Another important point to be seen here is level 5 and 6 don't have a right and left designation, which means any involvement can only designate a patient as N2. Of course, a very important point that is mentioned in this slide is that if you have certain risk factors, as I've mentioned in the previous slides, and the patient has a negative evaluation on an EBUS EUS, you can still go with a surgical staging with mediastinoscopy. Next slide, please. So let's concise what we've learned. So when is invasive mediastinal staging indicated? Is it indicated in all centrally located tumors? As of now, yes. If you see the ESTS, ACCP algorithms, and if it's a peripheral tumor less than 3 centimeters, then you might sort of get away with not doing an invasive mediastinal staging, provided your radiological evaluation is negative. But if a tumor size is more than 3, you do need to do an invasive mediastinal staging. If there's extensive infiltration of the mediastinum with no evidence of extrathoracic disease or N1, you need to do it. Bulky N2 on CT, there is no need for invasive confirmation. Now, bulky N2 has been defined variously by various guidelines. ESTS, ACCP define it as nodes larger than 2.5 centimeters, or if there is a confluent mass and individual discrete nodes are not visible. Discrete N2 you need to do. And again, if your CT is normal and your PET is positive, you still need to do an invasive mediastinal staging. Next slide, please. Yes. So again, this slide is again a collation of the ESTS, ASTS, and ACCP recommendations. So you're staging a CA lung, you get a PET CT done, and so on a PET CT, there is no suspicious mediastinal lymph nodes. Patients clinically N0, and on the basis of previous risk factors that I mentioned, there is a low probability of unforeseen N2 disease. So you can proceed with radical surgery or radical radiotherapy if the patient's medically inoperable. However, if the patient's clinically N1 or clinically N0 but has a high probability of unforeseen or occult N2 disease on the basis of risk factors that have been mentioned previously, you should go ahead with a less invasive mediastinal staging option like EBUS or EUS. And then accordingly, if your mediastinal lymph nodes are negative or positive, you proceed further. If your lymph nodes are negative, you go ahead with radical surgery. And if your mediastinal lymph nodes are positive, you proceed with multimodality treatment. Looking towards the right side of this algorithm, if your mediastinal lymph nodes are radiologically positive, and if they are bulky or if it's a confluent mass, according to the ACCP ASTS, no tissue confirmation is required. You go ahead with your concurrent chemoradiation. If, however, the nodes are non-bulky, then you need some sort of tissue confirmation, and accordingly, if your mediastinal lymph nodes are positive, you go ahead with multimodality treatment. The interesting part is if your mediastinal lymph nodes are negative on an EBUS and EUS in this scenario, then you need to perhaps adopt a slightly more invasive approach, which we'll discuss further, such as a VATS or a mediastinoscopy. And if your mediastinal lymph nodes are still negative, only then can you proceed for radical surgery. If they're positive, you proceed for multimodality treatment. And I think this algorithm nicely summarizes what we've learned so far. Next slide, please. Yeah, so this is a very nice slide. It sort of shows all the modalities that we have to stage the mediastinum. If we look at this slide carefully, we'll realize that an EBUS versus EUS, there are certain advantages and disadvantages to each approach. An EUS is inherently a left-sided approach, so it will give you a better access to your level 5s and 6s and your level 8 and 9s, the lower mediastinal nodes. Whereas a EBUS will give you a better access to your level 10s and 11s and your peribronchial hilar nodes. Coming to a cervical and extended mediastinoscopy, both of them will give you good access to the level 2, 4s and 7s, but an extended one will give you an approach to your left-sided nodes, the level 5s and 6s as well. And a VATS, a right or left-sided, accordingly will give you access to the right or left-sided nodes, and a comprehensive VATS can give you access to a pretty much all the lymph nodes in the mediastinum. Next slide, please. And so finally, a look at the sensitivity of the modalities. As you move down from a CT to a VATS, the sensitivity increases. The lymph node stations that these modalities most appropriately assess are mentioned here, but we've already discussed them in the previous slide. So next slide, please. Yes, so again, so lung cancer started out very simply. Initially, it was said that the patient has a CA lung. Then the concept of non-small cell and small cell came out. And then there was histological breakdown into 4 subtypes. Then molecular pathology entered the spectrum, and Dr. Aparna has already discussed this in a presentation. And then the advent of immunotherapy. So lung cancer has come a long way, and I'll be talking briefly about all the targeted and immunotherapy agents, how they've come in, and whereon they have a place in the management. Next slide, please. Yes, so the survival has definitely improved. This is SEER data from 2020-21, which shows lung cancer specific survival improvement of 10%. What you can see on the left are mortality curves, not survival curves. So as you can see, the mortalities come down about 5 to 10%, depending on how you look at it. So we have made improvements, we have made strides, and let's see how we've done that. So next slide, please. Yes, again, so this has been discussed by Dr. Aparna, and so this is a very nice slide. It shows sort of how targeted and immunotherapy agents have come, their sequential indications. It's been a long journey of about 10 to 15 years, and right now we have a lot of targeted agents and as well as immunotherapy agents, and not necessarily in metastatic lung cancer, but in early lung cancer as well, and which I'll talk about in my next slides. Next slide, please. So again, this slide's a bit dated. So this is a list of all the possible fusions that are found in lung cancer. And while it is mentioned that there are 7 approved FDA therapies, I believe now in 2023, this is slightly more. There are certain therapies that target the KRAS, as Dr. Pan has mentioned. There are therapies that target the HER2 as well. Adotrastuzumab emtansine has come into the picture. So there are about 9 or 10 molecular alterations with FDA-approved therapies as of now. And without a doubt, molecular testing should be the standard of care in NSCLC at present. Next slide, please. Yeah, so this has not changed. This is a 2020 NCCN guideline, but it's pretty similar to the 2023 guideline. And this is basically the management of early stage lung cancer, which is predominantly what my presentation is about. So if you have a stage 1A tumor, and again, so we discussed about invasive mediastinal staging now, and your patient has undergone surgery, which would usually be the management approach in a stage 1A. If your patient undergoes surgery, what is the adjuvant therapy recommended? At present, the approach is observation. There is no proven benefit of neoadjuvant adjuvant care therapy. Moving on to stage 1B and 2A, and this is where we really need to have a multidisciplinary team discussion. Your 1Bs and 2As right now are your tumors sort of between, historically between 2 to 3 and 3 to 4 centimeters. And here numerous risk factors come into the picture. If you look at all the guidelines, there are various risk factors. There's a high grade, there's a lymphatic invasion, there is vascular invasion, there is visceral pleural invasion. Some say that a sublobar resection also precludes a higher risk. Some say that if there is a very high SUV more than 10, even that could be a consideration for adjuvant therapy. So again, this requires a multidisciplinary team discussion as to give adjuvant chemotherapy in this cohort. When you come to your more than 4 centimeter or larger tumors, adjuvant chemotherapy is recommended without a doubt. Neoadjuvant chemotherapy, now this is a very interesting concept. This has come of late, of neoadjuvant chemotherapy and particularly immunotherapy. But I believe this is going to be spoken about by future speakers. And when we come to stage 3, again, stage 3 is a very complicated sort of management algorithm, and I'll not be discussing a lot about the stage 3 in my presentation. Next slide, please. Yeah, so again, the patient undergoes surgery, and this is really one of the highlights of my discussion, because I want to particularly highlight the role of adjuvant immunotherapy and targeted therapy in early stage lung cancer, which is why I'm putting a lot of emphasis on what happens after surgery. If you have, so you have a stage 1 and 2A tumor, you've undergone a complete resection, you have a R0 resection. So then again, we've discussed that chemotherapy would be considered in certain high-risk patients. If you have an incomplete resection, then in early stage tumors, re-resection is preferred over RT, and chemotherapy would. So one very important thing that we need to know is the indications for chemotherapy do not change according to RT. if you need chemotherapy, you will get chemotherapy. Whether the patient is going to get adjuvant RT or not does not change the indications for adjuvant chemotherapy. And again, moving on to stage 2B. Now, when we move on to stage 2B and stage 3, resection and RT become equivalent options. And this is one of the things that I wanted to highlight in this slide. Both resection and RT are equivalent options here. And then the sequencing of RT and chemotherapy is the next important thing that we need to know. If the patient has had an R1 resection, you can sequence them either sequentially or concurrently, because there is a very nice sort of meta-analysis that says that there is no difference in survival if you do this. However, if it's an R2 resection, then you have to give concurrent chemoradiation. This is very important because the ECOG and RTOG trials that did this found a survival benefit of concurrent versus sequential. Next slide, please. Yeah, so the problem remains even in early stage lung cancer, after surgery, after radical therapy, almost 50 to 60% patients are going to recur. And both locally as well as regionally and distant recurrences are seen. And there's still a need for improvement of outcomes, which is where adjuvant targeted therapy and immunotherapy really came into the picture, which we'll be discussing in our further slides. Next slide, please. Yeah, so as far as adjuvant chemotherapy is concerned, if you see the ESMO guidelines, and here we have the Pignon and NSCLC meta-analysis, for a more than 4 centimeter tumors, there is no doubt there's a clear evidence of a survival benefit. It's the less than 4 centimeter tumors that really sort of need a multidisciplinary discussion regarding chemotherapy. And as is mentioned in this slide, again, this is why the tumors have been reclassified as stage 2 in the 8th edition of AJCC-TNM. Next slide, please. Yes, this is the famous LACE meta-analysis, which showed an OS benefit from post-op cisplatin in early stage NSCLC. The hazard ratio was 0.9. The survival curves kept on separating with time. So the benefit was 3.9% at 3 years and 5% at 5 years. There was a borderline benefit of cisvinorelbine against other regimens, but this was not statistically significant. It was borderline statistically significant, and this was the regimen that has been most commonly used in the trials that were put in this meta-analysis, like the JBR10 and the Anita trial. Next slide, please. Yeah, so again, there's another analysis by Pignon et al. And the Burdett analysis, which compared neoadjuvant and adjuvant chemotherapy. Well, it was a very interesting meta-analysis. It found that the benefit of neoadjuvant chemo in early stage is almost the same as adjuvant chemotherapy. So this is a very interesting slide. It shows that, and again, in patients who are given neoadjuvant chemotherapy, generally adjuvant chemotherapy is not given, and this is one of the reasons why. Next slide, please. Yeah, this is one of the highlights. This is one of the things that I really wanted to emphasize in my talk. Adjuvant targeted therapy, the ADORA trial, which has really changed the management of early stage lung cancer. And one of the things that we need to know about this trial was that they took 1B to 3 patients, and they found a benefit in both 1B, 2, and 3A in terms of DFS and OS. And this was completely resected, mind you. This it doesn't apply to your R1 and R2s. It applies to your R0 resections. So this is a very important point to keep in mind. And if you see the NCCN guidelines, adjuvant osimertinib is indicated in EGFR positive early stage lung cancer only in patients with R0 resections. And this is something that needs to be kept in mind. Next slide, please. Yeah, so again, and adjuvant immunotherapy is also entered into the picture. This is a slide from the Empower 010 trial. Even adjuvant atezolizumab has shown an improvement in DFS as well as OS. And the curves start branching relatively early, and they continue to maintain their distance, showing that the benefit is maintained over a prolonged period of time. This was in patients who had a PDL1 of greater than 1%. And again, both atezolizumab and osimertinib have had an improvement of about 10 to 15%, which is quite significant in early stage lung cancer. And I'll show this in the future slides as well. Next slide, please. Coming to radiation, again, we've already talked about early stage tumors where if they are medically inoperable, radiation is an option. And There have been numerous technological advances in radiation, and one of the very important points that I needed to highlight was that IMRT actually improves survival in stage 3 and T3, T4 tumors, which is something that I wanted to sort of impress upon everyone. This was a trial by Jagadish in lung cancer 2016. And even in the recently concluded RTOG trial, IMRT has shown to reduce dose to the heart, lower rates of grade 3 pneumonitis, grade 3 esophagitis. And we all know that increasing dose to the heart is associated with a higher risk of mortality in stage 3, again, as is evidenced by the RTOG trial. Next slide, please. So what is relevant to everyone else? Yes, again, you need to understand what is the difference between SBRT and IMRT. SBRT is generally something to the tune of more than 6 gray per fraction, generally 8 to 20 gray per fraction in lung. 1 to 5 fractions it's usually given in, and again it's used in early stage lung cancer, and this is why I wanted to mention it here. It's generally not used for large tumors more than 5 centimeters or node positive tumors as of now. Next slide, please. And if we look at lung cancer radiation in 2022, numerous advances have been made. 4D CT planning is something that takes into account the tumor motion, allows us to reduce our safety margins, reduce lung toxicity. Image guidance is taking periodic CT scans to review the patient's progress as well as deliver more precise radiation. And all these advances have made radiation a very favorable option in early stage lung cancer, particularly in the medically inoperable patients. Next slide, please. Yeah, so again, in stage 3 NSCLC, there was a very pivotal trial called the RTOG 0617. Now, what this trial told us was this trial wanted to assess whether there's any role of dose escalation. It studied predominantly stage 3 and stage 3B patients, but the plan was to study stage 1 and 2 patients as well if there was a definite benefit of dose escalation. However, this slide shows that this trial did not find any benefit of RT dose escalation. It was a 2x2 arm trial, and there was also the addition of cetuximab, which was assessed in this study. Again, no benefit of RT dose escalation, no benefit of cetuximab. And
Bharat, some technical glitch.
results have markedly improved with immunotherapy. Am I
Yes,
audible?
yes, Bharat. Yes.
The next slide, please. Yeah, so just summarizing, in stage 3 disease, as I've just mentioned, I've not discussed this in detail, and this is not the highlight of my discussion. I'm predominantly focusing on early stage lung cancer. So chemotherapy without radiotherapy is the standard of care after complete resection in stage 3. Now, this depends again on the post-op histopathology, as I've just mentioned. And obviously not just on the stage, but also on the patient's age, comorbidities, and performance status. Most trials of CTRT have included patients with ECOG PS0 or 1 and not 2. And this is something to keep in mind. Next slide, please. Yes, again, the Pacific trial was a very important trial. Uh, it's mentioned that what this trial did was they tested adjuvant durvalumab post.
Bharat, some technical glitch. Bharat, Dr. Bharat.
Am I audible?
Yes, some technical glitch. Yes, now audible.
Okay, so right. So I was mentioning the Pacific trial. So this was a placebo-controlled phase 3 trial of consolidation durvalumab in unresectable NSCLC. And what it did was it found a 10% OS benefit for patients who did not progress. And again,
Bharat, yes, some technical glitch.
changing.
Yes. Bharat, Dr. Bharat Dua. Dr. Bharadwaj, some technical glitch from your side? Connectivity problem?
Right. So adjuvant targeted therapy is targeted therapy and immunotherapy is not just restricted. Okay, let me just look at this.
Sir,
Yeah.
sorry for interrupting. You have to conclude, please, as we are running short of time.
Okay, all right. I'm almost done. Anyways, next slide, please.
Yes.
Right. So emerging treatment paradigms in SCLC. This has been discussed in detail with Dr. Aparna, and I'll just sort of move through these slides quickly. So just to highlight the important points, the two important treatment paradigms are targeted and immunotherapy. Yes, we have numerous trials which have shown a PFS and OS benefit in advanced CA lung when you compare it with chemotherapy, more so with ALK inhibitors. Next slide, please. Numerous molecular targets are there. Besides EGFR, ALK, we have MET, RET, NTRK, and HER2. Again, this has been discussed with by Dr. Parna, and I'll not discuss this in great detail. This is a very nice slide which shows all the particular trials, the targeted therapy approvals, and is good for rote learning, and just sort of goes to show the benefit that we've achieved with targeted therapy. Compare a PFS and OS of 6 to 8 months versus 14 to 25 months with targeted therapy. And again, this slide is showing the role of immune checkpoint inhibitors. The two predominant pathways that these two work on are the CTLA4 and PD1 and PDL1. And we don't have any TF inhibitors as of now in lung cancer. Next slide, please. Again, this is good for a historical review. It shows how immunotherapy has sort of evolved, numerous indications, numerous drug coming in with sempilimab, PD1, PDL1 inhibitor coming in 2021 for patients with a tumor proportion score of 50%. And so again, survival outcomes, again, marked improvement as compared to systemic therapy, quite similar to targeted therapy for immunotherapy agents in advanced CA lung. Next slide, please. And again, just highlighting this keynote trial showing the survival benefit. And these are some of the trials that have sort of given the indications of immunotherapy in adjuvant and the neoadjuvant setting. I mentioned adjuvant atezolizumab, which has come in, and it shows the Empower trial, which was responsible for this approval. And antibody drug conjugates are making their way. Adotrastuzumab and newer conjugates are making their way in lung cancer. In fact, now they're FDA approved. CAR T-cell therapy is a very interesting sort of concept. Historically, this was considered for liquid tumors, but now it's come in solid tumor as well. CAR T-cell refers to chimeric antigen receptor T cells, and it is when we sort of modify the T cells to overcome the immune suppression that is imposed on them by tumors. So when we modify T cells like this, they do not require signal 1, 2, and 3 from the dendritic cells and are much more effective than your conventional T cells. However, this is not there in the guidelines so far, but yes, this is a very sort of interesting area of research. And in the interest of time, I'll just quickly give my takeaway points. So the managing landscape, particularly because of targeted and immunotherapy, is fast changing in NSCLC, and even in early stage. Newer therapies have a huge potential to improve survival, particularly in early stage lung cancer. They've resulted in OS improvement, and I cannot emphasize how important it is that the ease of oral pill over infusions is an added advantage for targeted therapies. And given that invasive media staging will become very important in these tumors, particularly in terms of deciding therapies and adjuvant therapies, a pulmonologist is going to play a huge role in early diagnosis. And please include them in tumor boards now. Thank you.
Thank you, Dr. Bharadwaj, for such an excellent talk. Now, our next speaker is basically Dr. Sumit Goel. He is the Associate Director at Rajiv Gandhi Cancer Institute and Research Center, and he will let us know about the decoding treatment option for EGFR mutation in non-small cell lung cancer, adenocarcinoma specifically. Dr. Sumit Goel, the Associate Director of Medical Oncology from Rajiv Gandhi Cancer Institute and Research Center.
So, good evening, sir.
Good evening, Sumit.
So, just give me a moment, sir. Hope my slides are visible, sir.
Yes, visual.
Okay. So, after those two wonderful talks, so I'll be talking about the data that we have
for the patients who have EGFR mutations in patients who have unresectable or advanced lung cancer. So we know worldwide that lung cancer is the second most common cause. It is the second most commonly diagnosed cancer. 11.4% of total cases of cancer that are diagnosed every year, lung forms the second most commonest cause. Again, it is a leading cause of death also. So 18% of total cancer deaths which happen, they happen because of the lung cancer. So we once we come to the treatment, so there is a scope for improvement, and lung has gone a wonderful way in terms of precision medicine, and it set the parameters very high. So treatment wise also, the parameters which determine the choice of first line treatment in advanced EGFR mutated non-small cell lung cancer includes either it is we look at the progression free survival, OS, that we all want. Again, we need overall response rates at times. Again, one of the peculiarities of lung cancer treatment is the presence of the brain metastasis. So we know outcome becomes much like diminished outcomes are there if the brain mets are there, but it's not so in era of TKIs. And again, once we talk about the efficacy, we do discuss about safety and toxicity, quality of life. And again, no treatment at this point of time is like imatinib in CML. So we do need to have options available to us in subsequent lines when there is progression. So when we talk about osimertinib, it has provided us with the unprecedented improvement in PFS. This was shown by the FLORA trial. So the FLORA, if we look at the different studies, so gefitinib, IPAS, erlotinib, optimal, afatinib from Lux Lung trials, Archer from decomitinib. So progressively, with the first generation and the second generation and third generation TKIs. With osimertinib, it has become 18.9 months, which was really unprecedented at that point of time. So if we talk about the progression-free survival, Lux Lung 7, it compared afatinib versus gefitinib. The PFS was almost the same, 11 versus 10.9 months. But again, the Archer, dacomitinib versus gefitinib. So the PFS was 14.7 months versus 9.2 months. And Flora showed 18.9 months of PFS versus 10.2, which compared it with the first and second generation of TKIs. But again, the important point to notice is the separation of the curves. In Lux Lung 7, it took almost a year before we could appreciate the differences which were there. In Archer, so the differences were happening around 6 months of time. But this study, it did not include the brain mets. So in the Flora, it was the Flora, the osimertinib, the third generation, the results were visible almost at the start. So, so the separation of the curves was immediate, almost immediate. So we could see the differences very early on. So, but again, this is a cross-trial comparison, so which we should be very careful about. So again, we can see an early benefit with osimertinib, which did not happen in the other studies, other drugs. So talking about the response to overall response rates. So again, if we look at the overall response rates in Lux Lung 7, where afatinib was compared with gefitinib, the overall response rates were to the tune of 70% in the afatinib versus 56% in the gefitinib. Median duration of response, if we talk about in the same study, it was 10.1 months as compared to 8.4 months. And disease control was fairly good, 91%. And the median duration of disease control was about 12.7 months. So if we come to the Archer again showed about the same overall response rates, 75%. There was some increment when dacomitinib was compared. So again, this study showed there were some responses which were even complete also. 5% versus 2%. Again, a good disease control rate. And the duration of response, again, it was 14.8 months. There was some improvement as compared to the Lux Lung 7 study. But once we come to the flora showed a massive 80% response rate. So it was highly effective. Results were visible earlier. Though there were complete responses, the disease control rate was almost like 90 plus percent. So again, the duration of response again was impressive, never seen before. At that point of time, it was 17.2 months versus 8.5 months, almost double that of the first versus the first and second generation of this. Again, the disease control rate were there at 12 and 18 months also, and significant number of patients were still responding to the osimertinib at that point of time. So osimertinib did show us the highest overall response rates and the median duration of responses. So if we talk about the flora, which showed the final analysis of overall survival, so osimertinib, again, the median OS of 38.6 months as compared to the comparator arm, which showed 31.8 months, significant p-value. Again, median OS was still higher as at 3 years. So again, they were, as we can see from these curves, they were separating quite early, and this separation is still maintained at 3 months, at 4 months, 4 years also, 3 years, 4 years also, and significant number of patients were still alive at second, third, and fourth consecutive years. So it was the first time that EGFR TKI has translated PFS to a significant OS benefit. So if we look at the Archer Lux 7 and Archer 1050, so it did not translate into OS advantage. The same way in the statistical analysis, the Archer also did not show the significant. It was not statistically significant. So the Flora was the first study which showed there was a translation of PFS into OS advantage. So if we look at the guidelines, so again the same thing. So the statistical design of Archer 10150, it, it also excluded the patients who had the brain metastasis. Still, it was not statistically significant. So the Flora showed at 3 years again, about 30% of the patients were still receiving osimertinib, and which was 3 times the more than the patient in the comparator arm. And still at the time of data cutoff, the patients were still 22% of patients were still on osimertinib. So the Flora, again, the osimertinib, it demonstrated a superior systematic PFS benefit regardless of the CNS disease status at study entry versus EGFR TKI comparator arm. So we know if the patients with known brain metastasis, which were there in about 116 patients, the osimertinib, median PFS in these patients in whom they had a stable or treated CNS metastasis, median PFS was about 15.2 months as compared to 9.6 months in the comparator arm. But in the patients who did not have CNS mets, the median PFS was much higher. So 19.1 months as compared to 10.9 months. So though with all the TKIs at it will happen and during the natural course of the disease, the CNS progression events occurred in 6% of the patients who were receiving osimertinib versus 15% of the patients who were on the first versus second generation TKIs. So a significant reduction. So if you look at the intracranial CNS PFS, so again, the median CNS PFS was not reached in the osimertinib arm as compared to 13.9 months in the comparator arm. Significant p-value and hazard ratio of 0.48 favoring the osimertinib arm. So with brain mets, we all know osimertinib is the drug to go to, which has a good penetrability in the brain. So the same thing in the tabular form. So in the significant CNS responses were there in the first line osimertinib in patients who had mutated EGFR status. So a response rate in the intracranial, if we look at, it was 66% versus 43%. And the median CNS PFS, as stated earlier, was not reached versus 13.9 months. So safety, whenever we talk about the benefits, we do talk about the side effects and the safety. So the side effects, as we know, were the same, like the rash, dermatitis, diarrhea, maculopapular rash, the pustular rash. The grade 3-4 A's with dacotinib were reported in 63% of patients in Archer 1050. And with afatinib, it was reported in 31% of patients in Lux Lung 7. However, it were the grade 3 or more side effects were there in Flora trial, which used osimertinib in about 18% of the patients. So grade 3 and grade 4, second and third generation EGFR toxicities. So osimertinib, the rash was much less, paronychia was much less, diarrhea was there but much less. Again, the stomatitis, which is a very intolerable side effect, was much less. So which was quite higher in the other two studies. So again, once we know we have to continue the dose reductions in EGFR TKIs, the second generation EGFR TKIs, afatinib and dacometinib, have shown to frequently cause adverse event which need a dose reduction. So in Lux Lung 7, about 41.9% of patients required dose reductions. In Archer, 67.4% of patients required dose reduction. Whereas in Flora, so it was just 5%. And whereas in the comparator arm, it was only the 4% requiring. So well tolerated, very few patients requiring dose reductions. So good tolerability there. So quality of life, again, we can see the quality of life, the global quality life was improved from baseline in the Flora trial in both the subgroups, but it was quantitatively better in the osimertinib arm. So at some point of time, we know our patients will progress. So how to sequence? That is the question. So 1/3 of all patients who were treated with first or second generation EGFR TKS upfront, they were able to receive second line osimertinib. Uh, so which is very less number. So if we look at if we start with the 10 patients who had EGFR mutations to begin with, approximately 73 to 77% of patients, they go on to receive the second line therapy. So the 30%, they will either die or they will progress or they will become candidates for palliative care only upon. And 60 to 70% of the patients, they will only go for T- T790M mutation. Either they will not be eligible for repeat tissue biopsy, or they will be insufficient tissue, or patients will not be keen, or so about 60% of the patient, 40% of patient will lose there, and about those 60 patients, 50% will have a valid test result which is positive for T790M. So 3 out of 10 only will be eligible for second line osimertinib if we start with first or second generation of TKS upfront. So we will lose a significant number of patients who will not get the best benefit if osimertinib is given even in the later lines of the treatment. So access to second line, if we see across different lines, so majority, about 3/4 of the patient to 2/3 of patients were able to receive the second line. So about 30% of the patients, they will not receive the second line of treatment. So it becomes all the more important to give them the best therapy upfront. So if we talk about the real world experience, evidence of T790M after afatinib, so in Japanese study, it was 43% of 37 patients who had acquired T790M after first line afatinib. In Taiwanese study, again, it was 48% of 42 patients who were rebiopsied after afatinib failure and had acquired T790M mutation. In another study from the same country, about 28 patients who were treated with afatinib, it was T790M was identified in 32% of the patients. So about the patients, less than 50% of the patients will acquire T790M mutation. So again, sequencing becomes very important. So starting with prior generation EGFR TKIs and then treating those that developed EGFR T790M with osimertinib. So it looks very interesting and good on paper, but this is not optimal clinical care at this point of time because we do not know, we don't have mechanism to figure out who will get EGFR T790M mutation at the time of progression. And not everyone will be fit enough to receive additional treatment. We know 30% of patients, they don't even go on to receive second line of treatment. Again, the re-biopsy or tissue biopsies, they are not always successful. And and osimertinib, when given in first line, is associated with a significant benefit in first line. So the factors which we cannot account for in sequencing is toxicity to drugs, occurrence of T790M mutation, the sites of progression we cannot predict, concurrent morbidity which happen or the side effects that happen, we that are factors beyond our control. Again, we cannot influence the patient choices much. So if we talk about the data, the real world studies with first line osimertinib, so we have three studies. One is the flower, which was like the first line osimertinib in the real world, an integral prospective study. So this study, the patients uh, closer to what we see in our day-to-day clinical practice. So all the patients of white hair, median age was 68 years. Both adeno and squamous patients were there, done in Italy, and PS more than or equal to 2, about 12.7% of the patients, they were not uh, PS0 or 1, which is usually required in the clinical trials. Again, a considerable number of patients had brain mets at baseline, and comorbidity index of Charlson was more than 6, was there in 93.7%. Again, not many patients were able to achieve CR, but there was partial response and stable disease in 96% of the patient. Again, this had majority exon 19 deletion and L858R mutation, and rare and complex was also there. So again, the time to treatment discontinuation, median time to treatment uh, discontinuation, PFS, it matched what was there in the clinical trial setting also. So the real world data again matching with the what was there in the clinical trial setting also. So the same thing. So the osimertinib, the data from flower confirm the effectiveness and safety in the real world also. So what one point of this of caution, the incidence of venous thromboembolism was higher in patients who had received uh, osimertinib. So, but however, the difference was not reported according to the age, PS, comorbidity, and tumor load. So it was there irrespective of these factors. So, like if patients were supposed to happen, they will get it. So again, the OC effect, which again was a real world evidence, again, the median age was little higher, 71. And again, a mixture of adeno and squamous happened in Asian country, Japan. And again, brain mets, again, 31% of the patients having brain mets at baseline, PS more than 2, 17% of the patients. Again, the overall response rates were there in 76.1%, very close to the clinical trial setting. Again, if we talk about the median PFS, it was 20.5 months, and median time to treatment failure was 19.1 months. So again, matching the data from the clinical trial setting. So again, but the OC effect showed the pneumonitis of all grade was higher as compared to the flora trial. But this data is from one country, we cannot comment what was so. But again, the study showed, so again, thromboembolism risk was there, and pneumonitis. The other real world data is from Mykonos study. Yeah, so Mykonos, it was again, the median age was 70 years. The adenocarcinoma and squamous cell, again, 15% of patients were having PS more than 2, and brain mets at baseline, 33.6 patients were having brain mets at. So, so again, the data from real world matching with those from the clinical study. So if we talk about the guidelines, so guidelines say the EGFR exon 19 deletion in first line therapy, if we have detected it prior to start of the treatment, osimertinib is the drug we should prefer. And if it was discovered when we have already started the treatment, either we can control the planned systemic therapy, then switch on, or we can interrupt and then we can start osimertinib. And we can talk about this is again ASCO living guideline, which says the osimertinib maintains a strong recommendation for first line use in patients who have L858R and exon 19 mutation. So, so last slide summarizing. So osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in OS. The median OS benefit of greater than 3 years. It has set a new benchmark for osimertinib and provides a window of opportunity for management of patients with advanced non-small lung cancer with sensitive mutation. So again, it is the first time an EGFR TKI has translated PFS into OS benefit. So 30% of patients were still on osimertinib at 3 years. It is the only drug which can be given to patients with brain metastasis and T790M mutation. It is the safest and least toxic drug among all the options available as of today. Sequencing can't be considered the best strategy as almost 70% of patients will not be eligible to receive osimertinib in the second line. So again, the data which is available to us as of today, it confirms osimertinib as the first line standard of care in metastatic EGFR mutated non-small cell lung cancer. So with this, I stop my presentation here. I'll hand over back to you, sir.
Thank you, Sumit, for such an excellent talk. Now we have a case-based panel discussion, and I would like that every speaker will participate in this. We have a panel discussion, and we have a faculties like Dr. Roshan Sarup Sharma. He is a senior consultant, interventional radiologist at Venkateshwar Hospital. Dr. Tarun Bhattnagar, senior consultant, chest physician at Venkateshwar Hospital. Dr. Anuja Anand, the head of the Department of Nuclear Medicine, and my speakers, those who spoke regarding this lung cancer. Now I would like to discuss the how you will manage early lung cancer patient, a case-based study for all of you. This 67-year-old gentleman, non-smoker, presented with mild cough. X-ray chest showed a small lesion in the left upper lobe, and the PET-CT scan showed lesion in the left apical lobe. And this is the picture of PET-CT scan. There is a finding which I want to discuss with you, that there is a FDG-avid, well-defined lobulated soft tissue nodular lesion in the apico-posterior segment, left upper lobe, with adjuvant pleural tag, feature suggestive of primary neoplastic lesion, no FDG-avid subcentimetric prevascular lymph node, likely non-specific reactive nodes, and no other evidence of scan which suggests dissemination of disease, and the biopsy is suggestive of adenocarcinoma lung. My question to Dr. Roshan Sharoop, how you will go for a CT-guided biopsy if the chest physicians are not available? Dr. Roshan.
Good evening, sir.
Good evening.
As I am viewing this case, actually, the lesion is somehow peripheral location.
Yes.
But it's being surrounded by the rib and the scapula.
Yes.
So the reach to the lesion may be somehow difficult, but we could approach the lesion after putting the patient in a prone position.
Yes.
And we'll go back from the back.
Yes.
And we accordingly will mark the needle and we'll place the site from where to insert the needle. Then we'll take the biopsy from this lesion, from the metabolically active area on.
Okay.
There is mild chances of pneumothorax and hemorrhage in this case.
Okay. Okay.
Post-procedure complications.
Or would you like to recommend the chest physician to do the bronchoscopy? Dr.
Sure,
Tarun
sir.
is here.
If the chest physician is available, first I would suggest to have a visit by the chest physician to go for bronchoscopy guided biopsy.
Dr. Tarun, what is your opinion?
Good evening, sir, and
Good
thank you
evening,
for inviting
Tarun.
me for the panel discussion. So this lesion is, as Dr. Roshan said, it is on the left upper apical segment, and it is surrounded by the normal lung parenchyma. So there are chances of pneumothorax. Also, it is a lesion is higher up, so the scapula would be an obstructive, would cause obstruction in the needle. So we could approach this lesions very well and with our radial bronchoscope. With the radial bronchoscope, we can localize the lesions. It is a 2 centimeter lesions can be easily be localized, and then we can take multiple biopsies, which we can then send for histopathological examination as well as for IHC for better treatment options that can be given to the patients.
Dr. Tarun, would you like to go for a pulmonary function test before doing any bronchoscopy in such patient? Suppose patient is 60 plus, I mentioned 67.
No, sir. Pulmonary function test is not recommended in doing a bronchoscopy.
Okay.
For the bronchoscopy, we have to basically look for the coagulation parameters and other cardiac health of the patient. Bronchoscopy, I would like to do before if you start the patient on any immunotherapy to see if what are the pulmonary criteria and what is the degree of fibrosis and other pulmonary health of the patient, but not for the bronchoscopy. It's not recommended.
Dr. Sarup, Dr. Roshan,
Sir.
any other imaging would you like to go for such patient, those who are having early lung cancer?
Sir, generally, PET-CT is the one-stop shop nowadays to stage the CA lung.
Okay.
But to evaluate for brain metastasis,
Yes.
we go for contrast MRI of the brain.
Okay.
To look
Dr.
for the
Bharat,
metastatic workup.
Dr. Bharat, as a radiation oncologist, any imaging test? Dr. Sumit Goel, as a medical oncologist, any imaging test would you like to go for early lung cancer? Dr. Bharat?
Yeah, good evening, sir. Again, a PET has been done, sir. It looks to be a more than a 2 centimeter tumor.
Yes.
I don't know the exact dimensions. I don't believe they were given.
Means T2 lesion.
It's a T2 lesion. So
Yes.
if it's a T2 lesion, then I would definitely like to go for an MRI brain besides a PET-CT. And what is the exact size of the lesion, sir?
Roughly 3.4 centimeter.
So it's a 3.4 centimeter, looks to be a central lesion. Again, a bronch, a PET-CT, and an MRI brain. I think that would suffice as the initial staging workup. And depending on the results of the bronch, I would like EBUS, EUS, and probably sample level 2, 4, and 7.
Means we have adenocarcinoma in a biopsy.
No, sir. I meant regarding the mediastinal staging. So I would like a EBUS and EUS to stage the mediastinum, as it looks to be an upper lobar lesion. So as per the ISCLC recommendations, maybe stage the 2, 4, and 7, level 2, 4 lymph nodes and the 7 as well.
Pat didn't mention anything in the lymph node in the mediastinum.
Yes, but it's a central tumor, and you said it's more than 3.5 centimeters.
Yes.
I would recommend mediastinal staging from a less invasive approach, maybe an EBUS or a EUS.
Dr. Tarun.
Yes, sir.
Means Dr. Bharat want an mediastinoscopy. Instead of that, he will go for EBUS. What is your recommendation in a tumor which is 3.4 centimeter? Pats did not mention about anything in the lymph node, only non-specific thing. What is your advice as a clinician?
Sir, I agree with Dr. Bharat. Patient who's having a central tumor of this size should definitely go for EBUS mediastinal lymph node staging. Because many a times the FDG uptake would not be that much, but the lymph node might come out to be positive, as we have seen in several of our patients earlier also.
Okay.
So EBUS staging should be done, and it is also not recommended that the EBUS staging should be done before you start the treatment.
Dr. Sumit Goel. Dr. Sumit Goel. Dr. Bharat, would you like to go for any special test?
अरे देखना चाबी.
Hello. Hello, Dr. Bharat.
Yes,
Doctor?
yes, sir.
Yes. Any tissue sampling technique means you want any special test in adenocarcinoma, as Dr. Arpradhar mentioned. If she is available, she can explain. Or you can explain. You mentioned about that.
Yes, sir. No, I don't know if she's available or not. I can't see her in the.
Yes. But you can explain. There is no problem.
Yeah, no, absolutely, sir. I would like EGFR ALK as well as the PDL1 testing in this patient. You see, again, you mentioned that it's a T2 tumor.
Yes, T2.
Yeah, so this patient. Yeah, so as per NCCN, so this patient would be a candidate for chemo followed by osimertinib, depending if we have an EGFR exon 19 or 21 L858. So I would consider the patient for a EGFR testing, and again I would also like a PDL1 in this patient. This patient is 3.4 centimeters. He might not no. So 3.4 centimeter would not be a candidate for atezolizumab or pembrolizumab. I believe it's in more than 4 centimeters. So maybe
Yes,
an
more
EGFR.
than 4 centimeter.
Yeah. So I think EGFR testing should be enough, sir, in this patient.
Okay, okay. Dr. Bharat means suppose patient is having a financial constraints.
Right.
He's a rickshaw puller.
Right, sir.
Can afford much. What is specific test would you like? Arpana mentioned about NGS. Sometimes patient cannot afford. So what are the basic 3 tests would you like to advise in such cases?
Well, sir, so this is I believe is the patient a smoker, sir?
No, adenocarcinoma, non-smoker.
Adenocarcinoma, non-smoker. So I think EGFR, ALK, and PDL1 would be the 3 tests that I would advise.
Yes, these are category 1 recommendation from the NCCN guidelines.
Yes.
Tarun, actually just see early stage Bharat.
Yes, sir.
Do you recommend a MRI brain in a stage 1B?
So in
1B.
I'm sorry.
I'm not talking about this in 1B.
No, I'm sorry. I think Dr. Tarun was about to say something, sir.
No,
Dr. Tarun?
I'm not sure whether MRI should be done in 1B staging. I think Dr. Bharat or any of the oncologists would be.
Dr. Roshan.
Sir.
Suppose patient is having a stage 1B lung cancer, not stage 2. Would you like to go for a brain MRI in such cases?
Sir, I think as a basic protocol, we should go.
Means if you see the guidelines, say it's optional. Yes, stage 1B is a optional MRI. Stage 1A, no MRI. And stage 1B onwards, you can go for a MRI brain. As a consultant of radio diagnosis, what is your opinion? How many cases you can see a brain mets in stage 1B?
Stage 1B, the case of brain mets are not much, sir. But suppose in some percent of cases there is, suppose we have not done the investigation, and suppose in some cases there is a mets, and later on patient present with metastatic disease, so then we will not be able to differentiate whether it was present prior or it's the new finding.
Okay. So stage 1B onwards, you can go for a MRI. Optional is 1B and followed by MRI in all these stages. Okay.
Yes, sir.
Tarun, any role of medicinal staging in early lung cancer? Before surgery, during surgery, after surgery? As a chest physician, what is your opinion?
Sir, once the patient is diagnosed or is a suspect of lung cancer, we should be doing mediastinal lymph node staging, sir.
Okay.
If normally it is recommended that if we are diagnosing a case and we find that the FDG is high and is a strong suspect based on the other clinical radiological parameters, then mediastinal staging should be done on the same setting.
Okay, before
we
surgery.
send a sample. We can send a sample from the biopsy for a Rose examination, which tell us that this is a high probability. And similarly, we can do a Rose of the mediastinal staging. So by the time we have the reports, we also have a complete staging of the patient at that time.
So I'm just showing that the NCCN guideline shows that brain MRI with contrast is stage 2, stage 3, stage 1B optional. So this patient is basically Tarun.
Yes, sir.
US, no enlarged mediastinal lymph node seen, medically fit and underwent surgery. And Bharat, this is the stage T2N1, and just see tumor size is 2.9 is to 2.5 is to 2 centimeter, means T2 lesion, single tumor, and invasive adenocarcinoma, acinar, predominantly micropapillary 25 to 30, moderately differentiated, visceral pleural invasion positive, LVI negative, spread through airspace, focally seen, and basically margins uninvolved, and the regional lymph nodes except the label 10 and 11 out of 3, 2 positive. Rest of the 2, 5, 6 to 7 labels are negative, and clinically EC absent, and clinically pathologically T2N1 disease.
That is,
Dr. Bharat.
Sir, in this
Yes.
patient, if the mediastinal lymph node staging would have been done, even as you can see, this is a very nice case that you have presented, sir.
Yes.
In this patient, the lymph node reported in the PET scan were non-avid.
Yes.
Yes. Two of the lymph node stations at 11 and 10, that is basically the higher lymph node station.
Yes.
They have come out to be metastatic positive.
Yes.
So it's a very nice case because it can show that despite the patient PET showing no FDG uptake, the lymph nodes can still be positive. And lymph node staging should be done if you are suspecting, lymph node staging should be done before the patient goes for surgery.
Even the
Very
size
nice
is approximately touching 3 centimeter, 2.9 is to 2.5 is to 2 centimeter.
Yes, sir.
Dr.
Yes.
Bharat.
Yes,
Dr.
sir.
Bharat.
Right, sir.
Just see the size, tumor size, and node positive at nodal station 10 and 11. If you see,
Right.
lung is having a 14 nodal stations.
Yes, absolutely, sir. So
my question is, do you check any molecular biomarker? Means you mentioned about the EGFR, PDL1, and ALK.
Right, absolutely, sir. This patient would be a candidate for EGFR, ALK testing as well as a PDL1 testing, and the adjuvant therapy. He would be a candidate for adjuvant chemotherapy.
Yes.
It appears to be an R0 dissection. I don't think he needs radiation, but he would get adjuvant chemotherapy, cisplatin doublet base, followed by adjuvant osimertinib or adjuvant immunotherapy, depending on his report.
Yes. Bharat, means such patients, how many patients undergo resection? If you see as a radiation oncologist, you are discussing these cases in tumor board, what is your clinical experience? How many patients you can go for a resection in such a stage?
So it's mentioned stage 1 to stage 3A. I would like to mention that we don't see a lot of stage 1 and stage 2s in our OPD.
Yes.
We don't usually see a lot of stage 1, stage 2. I think if we were to take out our own data, and we are taking this out, we have about 20 or 30% patients who are stage 1 and 2, and about 60 to 70% who are either stage 3 or 4.
Yes, you can say 2/3 patients are having a locally advanced.
Absolutely,
stage
absolutely.
3A, stage 3B, and 4.
Absolutely, sir.
Dua, your choice. Role of radiotherapy you mentioned in early lung cancer.
Okay. So, role of port in early stage NSCLC. If we refer to this patient, as of now in early stage lung cancer, one of the indications that's given by the NCCN is an R1 or R2 resection.
Yes.
There are some other indications, but the NCCN does not endorse them as such. It's mostly in R1 and R2s. And if we were to consider the role of SBRT in early stage lung cancer, so if I were to refer to this patient would be a candidate for SBRT if he were medically inoperable for some reason. He has a central tumor, but it's not an ultracentral tumor. It's about 3 centimeters or 3.4 centimeters.
Approximately, yes.
As you mentioned. So he would be a candidate for SABR, and he would be a candidate for SABR. And but I would again like even if I take him up for SABR, I would like some sort of tissue proof before that, because there are certain trials that have been published recently of wedge resection and lobectomies, which show that almost 5 to 10% of such tumors eventually turn out to be benign.
Okay.
So I would even PET positive ones. So I would like to sort of have a tissue proof, and we could take this patient up for SABR. Otherwise, SABR is generally indicated in less than 5 centimeter node negative tumors as of now.
Bharat, you shown me the new adjuvant chemotherapy. Even the Dr. Sumit mentioned about that.
Right, sir.
How do you will feel in a recent era that new adjuvant chemotherapy in stage 2 adenocarcinoma?
So in this patient, so are you're talking about this patient, sir?
Yes, yes.
So again, neoadjuvant chemotherapy, there's a lot of data coming in. There's neoadjuvant immunotherapy also coming in as well.
Yes.
And so
size is more than 4 centimeter.
Yes, absolutely, sir. So right now, as I showed in the guidelines, 1B and even up to 2A, as of now in the guidelines, neoadjuvant chemotherapy is not a recommended option.
Yes.
But one of the reasons that neoadjuvant chemotherapy is given in early stage lung cancers is particularly when the patient is perhaps not amenable to a lobectomy.
Yes.
And again, you can consider it in your early stage lung cancers. If they have a node positive disease, you can consider them in single station N2s, but they are your stage 3s if you are considering them for a surgical option. But as of now, neoadjuvant chemotherapy in early stage lung carcinoma is probably only indicated when you are your patient's not a candidate for a lobectomy.
Yes. And you mentioned about role of adjuvant chemotherapy oblique the TKI.
Right, sir.
You have shown me the data, you have shown me the real world presentation that these are the evidence. How do you rank the TKI role in a adjuvant setting if those who are having a T2N1 disease?
Okay, so in this particular patient, yes, he would be a candidate for adjuvant osimertinib as per the ADAURA trial. And as I showed in my overview, it has led to a significant improvement in PFS as well as OS. The median PFS at the time of early reporting had not been reached. So this is a very significant sort of advantage in these particular patients. And if we are talking about adjuvant chemotherapy, again, I showed the LACE and the Pinion meta-analysis. So this patient would be a candidate for a cisplatin doublet.
Yes.
Cis-vinorelbine is the most studied regimen.
Yes.
And so probably cis-vinorelbine would be one of the regimens of choice.
Yes. Yes. This is the data.
Yes.
As per the stage, the advantage, 5-year survival. I'm not going in detail. I'm just showing that this is the benefit of adjuvant cisplatin development, which you are mentioning, 5-year survival. And this is the osimertinib data, which you are discussing regarding the ADAURA trial, that yes, there is a role. And this is the baseline characteristics of this. And the question is, can we ignore this disease-free survival hazard ratio in a trial? The graph is clearly showing, and there is an advantage seen with the ADAURA trial that adjuvant, there is a role of osimertinib. So what are the recurrence pattern in such patient? Dr. Dua, how many patient can have a brain mets? How many patient can have a bone mets?
Well, okay. So again, so you've already shown the data, sir. So
yes, 38% versus 61%.
Yes, absolutely, absolutely. And this is one of the most sort of important slides of this trial, which shows that it actually changes the pattern of recurrence, not just provide
Yes.
a PFS and OS advantage, but actually
Yes.
changes the pattern of recurrence.
Yes. So you would like to go for a whole brain cranial artery, or depend upon the multicentric disease versus the 2 or 3 big size tumor, you will go for SBRT in brain addition?
Okay, sir. So I believe you're asking about a patient who is EGFR positive and has brain mets. What would be the approach?
Yes, yes.
Okay, so this is a very sort of interesting question. There is a slight sort of disparity in the guidelines, but I believe the most comprehensive review of this you will find in UpToDate. What UpToDate says is that you can take two approaches. If you have multiple lesions, so the number of lesions don't matter, but the patient should be asymptomatic and a candidate for EGFR inhibitor, of course. So you can start upfront osimertinib and avoid brain radiation altogether.
Okay.
Or you can take or the second approach, which they believe is equivalent because there's no head-to-head data, is that you give radiation, and you can also start osimertinib, and your radiation then would depend upon your number of lesions. If you have less than 10 or up to 10 lesions, you can do stereotactic radiotherapy. If you have more than 10, then you need to give whole brain radiation.
Bharat, my question is here. Everybody is having a doubt that once there is a brain mets, people are not talking about cure. But suppose there is a metastatic disease, oligomats or 2-3 mats, which is less than 3 centimeter. What is your approach? Curative intent approach, or people are talking about only palliative approach?
Okay.
Or
So
would you like to consult with the neurosurgeon and go for a surgical resection?
well, for a single dominant lesion, yes. A symptomatic lesion, yes. For multiple lesions at this point, no.
Yes.
And again, so if you see the trial of oligometastasis, which have included lung cancer patients, the Saber Comet trials, they did not have a lot of patients of brain metastasis, although the data is extrapolated, and it's now recommended that even patients with less than 5 brain lesions or up to 5 brain lesions.
Yes, that's why I'm saying that the concept is changing.
Yes, that data has been extrapolated in the guidelines, but again, they mentioned in the trial that these patients, they were a minority in these trials. So although they have included them in the guidelines, but I mean, I would still be a little hesitant in calling these patients curative. I believe we would be prolonging their life, but I don't believe it would be curative at this point.
I totally agree with you that people are sometimes talking about a theoretical aspect rather than the clinical aspect of the patient. As per the patient comorbid condition, the age, the time of the relapse, short period versus less than 6 versus more than 6 month period, very important. Dr. Bharat, you mentioned about that ADAURA trial.
Right, sir.
ADAURA practice changing?
Oh, absolutely, sir. Given the context of the benefit, the degree of benefit that has been seen in the ADAURA trial, I don't believe that's been seen in any adjuvant trial before it. And yes, I believe it's definitely practice changing and opens up avenues for so many more sort of areas of research and adjuvant therapies in lung cancer.
Any comment from any expert? Any expert who is giving their own opinion regarding the ADAURA trial or something? And this guidelines, this is old guideline, but the recent guideline again shows a role of osimertinib in stage 1B onward. And I personally feel thank you for participating in such a case discussion, such an excellent discussion done by the faculties of doctors. I thank all the faculties and the delegates, those who attended this lung cancer update for cancer treatment. I hand over the mic to Ansari for vote of thanks, please.
Thank you so much, everyone, for joining today's webinar. Excellent discussion. So till then, we'll meet somewhere else. So bye. Good night, everyone.
Thank you and good night to all of you.
Thank you, sir. Good evening.
Thank you.
Good evening, Bharat. We finished within the scientific program within a time.
Yes, absolutely. Thank you, sir. Thank you.
Thanks, Dr. Roshan.
Thank you, sir.
Thank you. Good night, sir.
Thank you, sir. Good night.
Good night, everyone.
All the faculties. Thank you and good night.